thank the club for the invitation and 2 excellent talks. James did a lot of the heavy lifting for that database for ITMIG, and we should be thankful for him. It's a powerful database, so thank you. So I'm going to talk about myasthenia gravis. And there's a lot of changing on the landscape with myasthenia with the recent publication, and hopefully some opportunities for us as a group to continue to grow rather than just being technicians for thymomas or thymectomy, hopefully. So I think one thing in analyzing data and understanding myasthenia gravis is how we think of how we as general surgeons, how surgeons versus neurologists and even oncologists sort of think about tumors. You know, for neurologists, it's about pharmacological remission and living with the disease. They don't even think of cure. We, traditionally, when we're looking at the graphs of myasthenia gravis, we're looking for who got the best cure rate, And they're like, what are you talking about? Nobody gets cured. We're just going to quiet them down with medication. So, you know, I don't know which paradigm is right, but certainly it'd be nice to know if we can cure these people long-term without chronic medications. And one of us has to convince them. So in terms of myasthenia, what do we know? What do we think we know? Hopefully, what will we know in the future? This is temporally related to the news these days. I guess that would be switched if I was in a medical conference. So don't run out of the room. It's not a medical student lecture. The MG pathogenesis, I put this slide up just to make sure everybody is up to date with the antibodies. Most of us grew up thinking of acetylcholine antibody. Myasthenias, just like most tumors, are not all created equal. So you really have to think about what's the genesis of the disease, because the treatment is different depending on the antibodies present and also the way the disease progresses and presents. So acetylcholine antibody is what we think about, what we usually test, and it's the #1 marker. But there's also muscle-specific kinase, or MuSK, which doesn't respond well to surgery. LPR4, another antibody, which is prevalent in a significant amount of patients, and seronegative. Now, how many people think seronegative is really seronegative? It's not seronegative. And at least 30% we know there's antibodies there with cell-based therapy, and it's just a matter of time before most of those become elicited, and probably the others. So I don't really believe in seronegative. There's probably something there, including antibodies directly related to the muscle sheaths themselves, sort of a pseudo myasthenia. But it's important for us to recognize those as we're sort of picking and choosing and let's call staging our myasthenics. So this is sort of what we call myasthenia subgroups, and help us decide prognosis and staging. This is the way the neurologists are going, and this is from a New England Journal review recently, which is a nice little review. It's pretty straightforward. So if you look at myasthenia, we usually see is either early onset or late onset. That's sort of the acetylcholine antibody positive patients. Less than 50, those are the ones we think of that respond well, generally have hyperplasia and acetylcholine antibodies. Late onset is over 50. They tend to have thymic atrophy. They still respond well to thymic resection, as far as we know. And they have acetylcholine antibodies. There's a subset within that we'll call the early onset, which is juvenile, less than 15. The data is sparse on them, but still probably respond to surgery. Of course, thymomas are related with acetylcholine antibodies. Then there's MuSK. LPR4 tend to have normal thymuses. And ocular, which is any age. Thymic pathology, big, small, round, big, is variable, and the acetylcholine antibodies are variable. Those are little surgeons. So where you see the little surgeons, that's where the neurologists.
They're all male.
What's that? Sorry.
All male.
Yeah, that's bad. Huh. All right, I'll update that. Got my train of thought off. So the neurologists accept now that for early onset and late onset myasthenia, pretty much it's accepted that surgery has a role. At the older age of myasthenia and the younger age, it'd be a little more controversial. Thymoma, obviously. What we don't know or is still considered not standard of care, or the neurologists are not going to refer, is for ocular, seronegative, MuSK, and for LRP4. That doesn't mean it doesn't make it right. It just means that's the state of the art for the neurologists. The drugs they use, everybody knows. I don't want you to get overwhelmed by this slide because it's boring. But, methadone and prednisone are the mainstays. Azathioprine, meclofenate are the next two. But then the up-and-comer is rituximab. Now we're talking about immunotherapy. This is sort of the opposite of immunotherapy. It's immunotherapy. It's just destructive immunotherapy. Rituximab, which for many diseases now is like a godsend. It's almost a miracle drug and has very little side effects, is being more widely used in myasthenia and aggressively used, and it's really showing some extreme benefit. This is the most up-to-date review of all the literature on rituximab. This does not include a prospective study that's just being finished under the auspices of the MGFA. So rituximab is a monoclonal antibody to CD20. It's 4-week course of the drug, once a week for 4 weeks, and then about 15 to 20% got a subsequent dose at 6 months. 169 patients, 60% were acetylcholine positive, and 34 were MuSK. And what you see is you had either a complete response or pharmacological response, that's PSR, CSR of 27% in the whole cohort, which is not bad for pure medical therapy. But in terms of control, MM is minimal manifestations or better. The MuSK antibodies patients had 72% control. That's important because surgery and all the other medications to date were really not controlling these patients. So now, what you should think of for rituximab, it's not first line yet, but certainly if you have a patient that's not responding to medication or had surgery and now has recurrent myasthenia and is not doing well, or just had surgery and is not doing well, you should consider rituximab, and insurance will almost certainly pay for it if they've gone through the routes of that. They're even paying for it up front in some patients, certainly with MuSK. So thymectomy for myasthenia gravis, historical background, where does the role of thymectomy come into play? Everybody knows Blaylock in 1941 described it, and since that time, it was all retrospective series that pretty much as surgeons we believed in myasthenia and resection, but there was no class 1 evidence from 1941 till basically the present. Because of that, although most of the people in this room believed strongly that thymectomy had a role in myasthenia gravis, 70% of neurologists around the world were not referring their myasthenics for resection because they didn't consider there to be enough proof to resend patients for thymectomy. So in fact, in 2000, the neurologic guidelines said benefit of thymectomy is not established conclusively. They considered it maybe, maybe not. And that just entrenched the neurologist to say, I don't think thymectomy works, I'm not going to send it. Some of that was changing with the role of minimally invasive surgery, but still, by and large, most neurologists were not sending us the cases. And the onus was on us. We never proved it. We got to prove these things. You know, it's a surgical procedure. We have to prove it. And retrospective data space, and even large databases with thousands and thousands of patients sometimes doesn't cut it. We got to do it the real way with prospective data. So Dr. Jaretsky and Newsom Davis, surgeon and neurologist, ganged up over many years and started the prospective trial of thymectomy and myasthenia gravis, the MGTX study and biomarker set trial. Now the results of this came out earlier this year, multi-center, international, single-blinded. What does single-blinded mean? That meant that the patient obviously knew that they had a sternotomy, but on follow-up, they all wore turtlenecks. Every patient had to wear a turtleneck. They passed out mock turtlenecks. So all the people that were assessing them for the next 3 years didn't know if they had surgery or not. They were randomized comparing thymectomy to thymectomy with prednisone. They were MGF class 2 to 4. 1 is ocular. 5 is basically intubated. 3, 4, and 5 are mild, moderate, and severe myasthenia. And they had to be antibody positive. So it's a select group. It was a very particular study. It was supported by the NIH with lots of money given out internationally, which may encourage us, if we want to do international studies in the future, that the NIH will fund these big collaborative projects. So compared prednisone alone to extended transdermal thymectomy combined with prednisone, and to look at, is there a greater improvement in myasthenic weakness? a lower dose of total prednisone, or enhanced quality of life and decreased side effects. So this endpoints are different than what we think of as surgeons, thus the first slide. It's sort of, are we controlling the disease in a proper way? We're used to seeing the results of myasthenia surgery as cure or no cure. The trial was designed to measure the effect of thymectomy on myasthenia gravis. Purely, that was the intent of the trial. There was really not much add-on except the bio-MG. At the time and presently, different techniques of thymectomy may widely vary in the extent of thymic resection. So to study this and get proper results, extended thymectomy through a sternotomy was chosen. So there's a lot of criticism, especially as we've evolved as surgeons, and we know we can do a good thymectomy. Why did you do a sternotomy? That seems ridiculous, because this could be qualitatively studied in a very exact manner across the continent. Additionally, just as the surgeons were required to be very specific on the surgery they did, and I'll go over, there was testing and courses you had to take as a surgeon, the medical treatment was just as regimented. They had very prescribed data on when they could give prednisone, when they could increase prednisone, when they could decrease prednisone, and all the patients were given special blister packs of prednisone that they had to hand in, and they would count the amount of packs used and not used to corroborate what their medication usage was. So it was a very tightly controlled study. Again, randomized patients of antibody-positive myasthenia gravis, class 2 to 4, randomized either way. Then after they were randomized to surgery or surgery with prednisone, you basically had a prednisone taper over the next 3 years. And that was very qualified as to when they could decrease the prednisone. They had to have quantitatively measured neurologic parameters that allowed them to decrease the prednisone. It wasn't like, well, I think you're doing a little bit better. And the composite results were looking at clinical status, medication status, and adverse events at 3 years. The composite primary clinical response, which is called the blinded, was the AUQM, which is the clinical measure of the neurologist for myasthenia. And I'll show you a grading score for that. As it's noted, it was a blinded evaluator, and I think over the course of the study, over 10 years, only 2 or 3 patients accidentally forgot to wear their mock T-shirts and so did the sternotomy. And then they had to change the blinded reviewer. Prednisone requirements were noted, and the prednisone dosing was dosed to minimal manifestation status. So they had a very strict requirement about what they had to do to decrease it. This was the QMG score. The point is not for us to learn that. The point is that all the neurologists, every time they saw the patients, had a very quantitative, not subjective, risk scoring system where they scored the patients, and they could only decrease the prednisone or increase the prednisone if the QMG score reached a certain level. Surgical methods of teaching, documenting, and verifying the surgical technique of maximal thymectomy were prescribed. Both the surgeons and the medical guys had to go to camp, had to go to school, basically, and get lectured about the prednisone dosing and the surgery, even though they were all worldwide surgeons, and take tests and look at videos, kind of like our present EMRs. The surgeons were required to review theory videos, technical steps, thymectomy, and agree to maximal transsternal thymectomy. Preoperative certification tests and operative notes and results were reviewed centrally. This is Dr. Jaretsky's original drawings of what basically was his operation, and it's basically a complete extended thymectomy from mediastinum phrenic to up under the inferior poles of the thyroid, basically trying to do as much of a complete exenteration of the mediastinum of all thymic tissue and mediastinal fat that may contain thymic tissue. Resection of the pleural bilaterally, and this is what the specimens would look like, and we all see lots of pictures of those. But everybody knows this technique, and everybody sort of can potentially roll their eyes, but you have to think about doing this over every continent in the world, basically, and trying to get the surgeons to do exactly the same procedure on all the patients so that in the end, after 10 years, we could say qualitatively whether there was an effect of thymectomy and not effect of a different surgical procedure on myasthenia gravis. Very important. And it's important that we were able to corral a bunch of surgeons to do the same thing for the good of the patients. So 68 centers, 18 countries, 6 continents, 32 US centers, huge amount of screening. I think Mark Allen or somebody asked me once about why so much screening and so many decreased, because the screening was wide open. Just anybody with myasthenia came in and they were screened. And then if they had a thymoma, they were unscreened. If they had class 1 ocular, they were unscreened. So it was basically, they considered screening anybody that showed up with myasthenia. Of that, 231 were eligible, 126 randomized, fairly even 60 and 60. And the enrollment began in 2006. Now, this probably looks familiar as we try to do surgical trials. It was painfully slow. 2006 to 2012, slow, steady enrollment. Frequency count, cumulative effect, and it took basically 6 years to accumulate 100 patients. We had to get an extension by the NIH to continue the trial, but they were encouraged by the prospective gaining of patients slowly but steadily. Ultimately, it came to fruition. This is where it was done all over the world, and in the US, you can see pretty much everybody is represented. Kind of like a James slide, there's certain pockets of, I'd say, myasthenia or thymic interest, and I'd say Argentina and Italy are clearly 2 of them, where they have a lot of contribution and a lot of academic and clinical interest in treating the disease. So these are the results. This is the quantitative myasthenia score, or basically this is the clinical status of the patient. So you can see prednisone up top. The lower you are, the better. So prednisone alone, thymectomy there. And you see a large, it's about a 30% improvement in clinical symptoms using sternotomy, using thymectomy and prednisone versus prednisone alone. What's striking to some of us is most of the results, see the big, we'll say difference or effect of surgery really occurs almost at a year. And sometimes we think of thymectomy as happening at 2, 3, 4, slowly occurring, but the majority of the effect in this trial, and the most prospective and well-documented trial so far, has been within 8 to 12 months that we saw a profound effect, and it still continued to slowly increase. So at the same time that these patients had better clinical symptoms, they also had lower prednisone dosing. So this is a slide of the prednisone dosing. Let's see, the prednisone count is low, and up here prednisone alone. So if they were on thymectomy with prednisone, they had almost, again, about a 30% decrease in their prednisone dosing. So they had about a 30% improvement in symptoms and a 30% decrease in prednisone symptoms. So almost like a double bang of clinical improvement. Now you may say, well, why weren't they off prednisone? Why weren't they have complete responses? Because they couldn't. The way the trial was structured, it was slow release of the prednisone, so we weren't even able to see who could have a complete response of this. This may follow because we're going to be following these patients over the bunch of next years. What else did we see? No significant difference in treatment-related complications between surgery and medical therapy, which is encouraging. That's with a sternotomy. Interestingly, the quality of life, the SF-36, showed no significant differences. I thought that was kind of interesting. Favoring thymectomy over 3 years. Number of patients with symptoms was significantly better for those that had thymectomy. Total number of symptoms was significantly lower for those that had thymectomy. Distress level related to symptoms was significantly better than those that had thymectomy. And exacerbations requiring hospitalizations was dramatically improved for patients that had thymectomy over no thymectomy, 9% versus 37%. All parameters that are encouraging. This is another highlight of the adverse events. Again, number of adverse events, you see there's a large discrepancy. If you look at thymectomy alone, there's a significant improvement in number of symptomatic events that the patients had. Life-threatening events was 12% versus 2%. Hospitalizations for myasthenia after the procedure or after the start of prednisone was significant, 52% versus 23%. And another exacerbation, nervous system disorder, myasthenia again, 37% versus 12%. So all the parameters of adverse events or exacerbations of myasthenia were markedly decreased over the long term for the patients with myasthenia that underwent thymectomy. Planned subgroup analysis. Interesting. So those the patients that had prednisone prior to thymectomy did better. Patients that did not have prednisone, so patients that showed up prednisone naive, no immunosuppression prior to thymectomy, showed no observed benefit. This was a small cohort of patients, so it's not clear if it's true, but it may be a real phenomenon. Sex, women did better. Women with improved clinical and prednisone dosing. Men only saw the benefit with decreased prednisone. They did not have improved myasthenic scores in terms of their neurologic status. Age, improvements were seen for less than 40 and over 40. So that gives us some turgor to offer this to our patients over 40. However, that's a caveat. There was a post hoc analysis of over 50, and that didn't show a benefit. However, that was a very small cohort because most of the patients were under that, so I didn't present it as a definitive. It's just something to keep out there and something we need to learn more about. So surgical specimens of resection were performed in a remarkably similar manner with an excellent safety profile. This is important when we're thinking about our future clinical trials. The study importantly proves the ability to measure a specific surgical technique among multiple surgeons and quantifies the effect of maximal thymectomy or whatever surgical procedure we decide to measure in thymectomy from MG. Maximal thymectomy is now the only proven surgical treatment for myasthenia gravis. Improvement to time and remission and overall cure is still an evolutionary goal. An ancillary to the study is biomarker MG, kind of like James was showing. The question is, are there other biomarkers that can help us dictate who's going to do better with medication or with other procedures? So looking at the genes, gene expressions, and protein in the patient's blood. Early results are not in. Dr. Marks is doing the TCGA study, so he's not going to really help analyze this data, and he's the lead on this till after he's done with the thymic tumor database. But early on of interest, basically, this is showing the grading of hyperplasia versus no hyperplasia for the patients that underwent resection, and basically early data shows that whether they had thymic hyperplasia or not probably is not a good predictor of who gets a response. So what is the best surgical approach to thymectomy? I don't think there is one best surgical approach. It's going to be efficacy, reliability, morbidity, surgical experience of the patients, and acceptance. I think you have to have a maximal thymectomy. My belief is that it really doesn't matter if it's done the sternotomy, VATS, RATS, subxiphoid, anything. That's the approach. That's not the procedure. What we know is that a maximal thymectomy, and if you perform a maximal thymectomy by any way, you should be able to get these same results. So this was an old MGFA classification showing the different standards of the way that we can resect things, and it's going to continue to grow as people think of novel ways to resect the thymus. But I would say that we should get rid of that classification. It should just be either you're going to do a maximal thymectomy or a basic thymectomy if you want to compare things. Although I don't think it's a great question anymore. I'm going to pontificate for a second here. This is a slide that everybody's seen for a while. This is fact. It's not fake news. We know that there's thymic rest and extrathymic tissue throughout the mediastinum, and especially lateral to the phrenic nerves, 72% of the patients. Again, this is all pathologic data. In the fat of the mediastinum, near the diaphragms, in 30%. Extracapsular mediastinal lobes, 90%. AP window, 24%. I recreated that at Columbia, sending true AP window nodal resection and finding thymic tissue in there. Which, if these thymic rests are important or not, is not proven, I would say. But what is proven is that the better, I think, as proven as it can be retrospectively, is that the more thymus you take, or the less you leave behind, the better they do. I added this slide for Blair, who we were talking about resection last night, and said, maybe, why didn't you do a sham? I don't know who knows Marcin Zielinski. He's a Polish surgeon who's a fabulous surgeon, and he for years was doing a basic thymectomy through a sternotomy. Open a sternotomy and just do a simple basic thymectomy, not a radical. Then he changed his own plan through a sternotomy and started doing extended thymectomies. His own data, one single surgeon, showed a dramatic improvement, so the sternotomy itself was not the sham. could not be the intervention. One intervention showed a dramatic improvement in overall response. And this has been shown over and over and over again, that maximal resection of the thymus does better no matter how you do it. So, transcervical thymectomy, it can be done, you can have low results, 23%, or 50% results. You can do it and get results. It's not the approach, it's the extent of thymic resection. Same thing with VATS thymectomy. You can do a VATS thymectomy basic, or you can do an extended. Same thing with robotic. Extended, Dr. Ruckert, I was in Berlin last week, does a beautiful, I think he does the most complete robotic thymectomy definitely in the world. Does both diaphragms really quite cleanly. And sternotomy as well. You can do a good thymectomy through sternotomy or a poor thymectomy. It's really about maximizing the results. So, Dr. Uretsky used to say, the less thymus left behind, the better. I'll give a caveat to that there's only so much we can take in the mediastinum. But if you take note, this guy does not have ptosis, because he'd be really screwed if he had ptosis. Still, despite all this improvement, basic thymectomy, maximal thymectomy, we've made some improvements, but we still are really only curing a minimal amount of patients. The question is, and it takes time. So can we do better? I think we can. I think it's open for surgical trials for us to think about myasthenia as a multidisciplinary treatment together, just like cancer. Should we give these guys induction? There's data about induction high-dose prednisone that out of Japan and out of Germany from years ago that was intriguing. And nowadays, the question is, and then in the trial, that patients that got prednisone did better than that didn't get prednisone in the prospective trial, make me think, well, if we gave adjuvant immunotherapy, we'll call it, say rituximab, then do resection, can we shift those curves over so that we get a rapid and more durable response to the myasthenics? These are trials that we could easily perform as a group. It would take a minimal amount of patients because the response rate overall to the intervention is so low that even with the small amount of myasthenics around, I think every 2 years we could easily get trials done, and it would not be too costly. So I would like to think about that as a group if we work together and try to push this, because we can't be satisfied with a 30% improvement in lifetime prednisone or rituximab. So I'll end there. Proof of thymectomy in the future, we still haven't proven ocular. That's probably the next multi-center international trial sponsored by the MGFA and the NIH. The NIH was, by the way, head over heels about that. They considered this one of the first prospective randomized surgical trials to finish, certainly in the neurologic action of the NIH. So they're eager to spend money if we can prove that we can finish trials proving or not proving surgery. Seronegative, not proven. Older age, not definitively proven. MuSK is actually the opposite of proven. It's discouraged. Cure pharmacological stability, multimodality approach, and surgery with or without induction. Thank you.